The word reversal is used carefully in medicine. Physicians are trained to be cautious with it. But when it comes to type 2 diabetes, the research evidence for genuine, measurable, sustained reversal through behavioral change is stronger than almost any drug trial currently in the literature. And the habits responsible for it are simpler, cheaper, and more immediately available than most people sitting in their endocrinologist's office will ever be told. Studies tracking adults who implemented specific daily behavioral changes found reversal rates, defined as HbA1c below 6.5 without medication, of 46% at 1 year and 36% at 2 years. Those numbers did not come from surgery. They did not come from new pharmaceuticals. They came from habits, 10 specific, daily accessible habits that work through distinct biological mechanisms, each one measurable, each one additive, and each one available to you starting today. I'm Dr. William. Decades in internal medicine with a concentrated clinical focus on metabolic disease, insulin resistance, and type 2 diabetes management in adults who were told this condition only progresses, never improves, never reverses. I started this channel because the gap between what the research shows about diabetes reversal and what actually gets communicated in a standard diabetes appointment is one of the most consequential gaps in all of medicine for the people it affects. We close that gap here. Before we go any further, drop a comment with your age and your most recent HbA1c or fasting blood sugar reading. Both numbers if you have them. I read every single comment. Those readings tell me precisely where people actually are, and they shape exactly what I cover next. Now here is the foundation before the 10 habits, because without understanding the actual mechanism driving type 2 diabetes at the cellular level, these habits look like generic health advice rather than what they actually are, targeted interventions into a specific biological cycle that can be interrupted and reversed. Think of your insulin signaling system like a lock and key mechanism operating on the surface of every cell in your body. Insulin is the key. The insulin receptor on the cell surface is the lock. Under normal conditions, insulin produced by your pancreas circulates in the blood, reaches the cell, turns the receptor lock, and glucose enters the cell to be burned for energy. In type 2 diabetes, the lock has been jammed, not broken, not permanently destroyed, but mechanically compromised by years of excess glucose, elevated chronic inflammation, and ectopic fat deposits inside liver and skeletal muscle tissue. The key is still being produced. The pancreas is working harder than it ever should, flooding the system with more insulin to compensate for the jammed locks. The cells are not responding adequately. Glucose keeps circulating, and the pancreas, straining to produce more insulin, is running toward exhaustion. Here is the part that almost never makes it into a 15-minute appointment. The lock is not permanently broken. The ectopic fat deposits jamming the receptor mechanism can be mobilized and removed through specific behavioral interventions, restoring receptor sensitivity without pharmaceutical intervention in a meaningful proportion of people who implement these changes consistently. The pharmaceutical industry has invested heavily in downstream management of insulin resistance and its consequences. The upstream reversal of the condition through targeted habit change generates no comparable commercial return. That is not a conspiracy. That is simply where the financial incentives point. Here is what points toward reversal. Let me show you the first habit. Number 1 is a 10-minute walk after every meal, and I need to explain why this specific timing is mechanically different from the same 10 minutes of walking at any other point in the day. Because most people who understand that walking is good for blood sugar completely miss the mechanism that makes post-meal walking categorically more powerful than their morning exercise for glucose management. The critical window for blood sugar is the 90 minutes immediately following a meal, the period during which glucose is being absorbed from the gut into the bloodstream. This is the postprandial glucose excursion, the spike, the peak, and the return to baseline. The height of that spike is one of the most important variables in long-term diabetes management and vascular damage accumulation, separate from and additive to the fasting glucose and HbA1c numbers that receive all the attention in standard appointments. During a 10-minute walk immediately after eating, your large leg muscles, the quadriceps, hamstrings, and calves, begin actively contracting. Contracting skeletal muscle activates a glucose transport system called GLUT4, which moves glucose from the bloodstream directly into muscle cells without requiring insulin at the receptor site. This is a non-insulin-mediated glucose clearance pathway. Think of it like a direct highway from the bloodstream into the muscle cell that completely bypasses the jammed lock. It has its own door, and physical contraction is the key that opens it. Research from the journal Sports Medicine found that a 10-minute walk taken specifically within 30 minutes of finishing a meal reduced peak post-meal blood glucose significantly more than a 30-minute walk taken before the meal. Same 10 minutes, categorically different metabolic impact because of timing. I had a patient, Thomas, 72, from Austin, Texas, a retired civil engineer who had been walking 45 minutes every morning without meaningful improvement in his post-meal readings. We added a 10-minute walk after each of his 3 main meals without changing anything else. His 2-hour post-dinner glucose readings dropped from an average of 218 to 147 within 6 weeks. His endocrinologist called him specifically to ask what he had changed. The action step: within 30 minutes of finishing each meal, walk for 10 minutes. A comfortable, steady pace is sufficient to activate GLUT4-mediated clearance. Applied to all 3 meals consistently, this single habit can reduce HbA1c by a full point, according to data from the American Diabetes Association. Number 2 is protein-first meal sequencing. And this is one of the most underappreciated interventions in the entire metabolic literature. For a mechanism so straightforward, it takes one sentence to explain, and yet most people managing diabetes never hear it at a clinical appointment. When you eat protein and fiber before carbohydrates within the same meal, the protein and fiber physically slow gastric emptying, the rate at which food moves from your stomach into your small intestine, where glucose absorption actually occurs. Think of gastric emptying like the rate at which grain pours through the bottom of a silo into the processing machinery below. Protein and fiber constrict that opening. The same total carbohydrate load that would spike your blood sugar rapidly when eaten first now arrives at the absorption surface gradually and steadily, producing a dramatically lower and flatter glucose curve from the identical meal. Research from Cornell University's Weill Medical College found that eating protein and vegetables before carbohydrates in the same meal reduced post-meal glucose peak by 37%, and insulin response by 21%, compared to the reverse sequence: same foods, same total quantities, different order. 37%. That is not a small number. That is the difference between a blood sugar spike that stresses your vascular endothelium and one that barely registers. The action step: at every meal, eat your protein source first, then your vegetables, then your carbohydrates last. This applies at restaurants, at home, everywhere. No preparation time, no additional cost, just sequence. Number 3 is vinegar before meals, and I want to explain the mechanism precisely because most people who know this tip treat it casually without understanding why it actually works. The active compound is acetic acid. Acetic acid activates AMPK, the master metabolic switch I have described in previous videos, specifically in the liver, where it inhibits glucose production between meals. But the mechanism most directly relevant to post-meal glucose is a separate one. Acetic acid inhibits specific carbohydrate digesting enzymes in the small intestine, primarily amylase and sucrase, slowing the breakdown of complex carbohydrates into glucose molecules. If glucose cannot be broken down efficiently, it cannot be absorbed rapidly. Think of it like reducing the rate at which a manufacturing line converts raw material into finished product. The same carbohydrate arrives, but the output rate slows, and glucose enters circulation in a more manageable stream. Research from Diabetes Care found that 2 tablespoons of apple cider vinegar consumed before a high-carbohydrate meal reduced post-meal glucose by 20% in adults with insulin resistance, with the greatest effect in those with the most compromised sensitivity. The action step: 1 tablespoon of raw unfiltered apple cider vinegar in 8 ounces of water through a straw to protect tooth enamel 10 to 15 minutes before your 2 largest meals daily. If you are on insulin or any glucose-lowering medication, discuss with your physician before adding this. The additive glucose-lowering effect is real and requires dosage awareness. Number 4 is 16 ounces of water first thing every morning before anything else, and the mechanism connecting morning hydration to blood sugar control runs through a pathway most people never consider: the concentration effect of overnight dehydration on circulating glucose. After 7 to 8 hours without fluid, blood plasma volume is reduced. The same total amount of glucose circulates in less fluid, producing a higher effective glucose concentration per unit of blood. Every single morning, your fasting blood sugar reading is influenced by this concentration effect before food has touched your stomach. Think of it like ink in water. The same amount of ink in half the water appears twice as dark. The glucose hasn't increased. The dilution medium has decreased. Research from the European Journal of Nutrition found that mild dehydration was associated with significantly higher fasting blood glucose readings in adults with prediabetes compared to readings taken following adequate rehydration, independent of diet or medication variables. The action step: 16 ounces of water as the first physical act of every morning, before coffee, before food, before medication. Make it automatic by placing a full glass on your nightstand tonight. This single shift measurably affects fasting glucose readings when practiced consistently across a full week. Number 5 is sleep extension and consistency, and I want to address the blood sugar mechanism directly because most people managing diabetes monitor food and medication carefully and never treat sleep as a glycemic variable, even though research has established it affects blood glucose as powerfully as dietary interventions and in some cases more rapidly. During sleep deprivation, cortisol rises and insulin sensitivity in skeletal muscle drops measurably. A single night of 5 hours of sleep reduces next morning insulin sensitivity by approximately 25% compared to 8 hours in the same individual. Not over weeks, not gradually. The next morning, directly and measurably. Think of it like additional jamming applied to the already compromised insulin receptor lock. Poor sleep is physically making the mechanism worse before you have eaten a single bite. Research from the University of Chicago found that restricting sleep to 5.5 hours for just 6 nights produced insulin resistance equivalent to gaining 10 to 15 pounds of body fat in previously healthy adults. 6 nights. That is how rapidly this variable moves the metabolic needle. I had a patient, Constance, 69, from Raleigh, North Carolina, a retired teacher whose fasting glucose readings swung widely week to week without dietary changes she could identify. Her sleep ranged between 5 and 8 hours with inconsistent timing across the week. We established a fixed 7-hour window with consistent bedtime and wake time across all 7 days. Her glucose variability reduced significantly within 3 weeks before any other intervention was added. The action step, consistent sleep and wake times across all 7 days, including weekends, is as important as total duration. Variable timing disrupts circadian cortisol rhythm in ways that accumulate regardless of how many total hours were logged. Before habit 6, I want to stop here. If what we are covering today is giving you a clearer picture of why your numbers have not responded the way you expected to, the changes you were already making, subscribe right now and share this video with someone managing blood sugar alongside you. This channel grows because people like you pass it to the person who needs it most. We have 5 habits left, and I would argue the next one is the most consistently underused intervention in the entire type 2 diabetes toolkit, despite carrying some of the strongest clinical evidence behind it. Number 6 is resistance training twice weekly, and the mechanism connecting muscle mass to blood sugar reversal is the most direct, most durable, and most consistently underemphasized relationship in metabolic medicine. Every pound of skeletal muscle your body carries is a glucose storage and disposal site. When insulin signals a muscle cell to take in glucose, that glucose is stored as glycogen, a form that is inert, not circulating, and not contributing to blood sugar elevation. The more muscle mass you carry, the greater your total glycogen storage capacity, and the lower the insulin demand required to clear any given glucose load after a meal. Think of muscle tissue like expanding the total parking capacity for blood glucose. More spaces means less glucose circulating in traffic at any given moment. And here is the part that makes resistance training specifically more powerful than aerobic exercise for this mechanism. Each session creates micro damage to muscle fibers that requires glucose for repair over the following 24 to 48 hours. Your muscles remain insulin sensitized and glucose hungry, not just during the workout, but throughout the entire recovery window. Research from the American College of Sports Medicine found that adults with type 2 diabetes who performed resistance training twice weekly showed reductions in HbA1c after 16 weeks, comparable to the effects of several commonly prescribed glucose-lowering medications. I had a patient, Douglas, 71, from Columbus, Ohio, a retired high school principal who had been prescribed metformin and told his diabetes would require progressively higher doses over time. He began a twice-weekly resistance program, chair stands, wall push-ups, resistance bands, and increased protein at every meal to support the adaptation. 14 months later, his HbA1c had dropped from 8.4 to 6.6. His physician reduced his metformin dose for the first time since diagnosis. He told me, "I was told this only goes one direction. Nobody told me I could change the direction." The action step, twice weekly, perform 2 to 3 sets each of chair stands, wall push-ups, resistance band rows, and calf raises. Begin at 10 repetitions per set and progress as your tolerance allows. Clear it with your physician if you have orthopedic or cardiovascular limitations. I need to stop here for the medical caution before we continue further. Several of these habits, the vinegar, the compressed eating window coming shortly, the increased exercise, can meaningfully lower blood glucose in ways that compound the effect of insulin and glucose-lowering medications you are already taking. Hypoglycemia from overlowering is a genuine and serious risk in anyone on insulin or sulfonylureas, including glipizide. Do not implement multiple habits from this list without informing your prescribing physician. Bring this video or a specific note to your next appointment and ask directly how your current medication dosing should be reviewed as your lifestyle changes take effect. The goal of these habits may be to reduce your medication requirements over time, and that outcome is genuinely achievable. But that reduction must happen under medical supervision, so your dosing adjusts with your biology rather than against it. Number 7 is daily stress reduction as an active glycemic intervention. And I want to be explicit that this is not a lifestyle recommendation. It is a metabolic one, with a direct hormonal mechanism connecting psychological stress to blood glucose elevation that operates independently of anything you eat. When your stress response activates from conflict, financial worry, news, chronic low-grade anxiety, your adrenal glands release cortisol and epinephrine. Both hormones signal your liver to release stored glycogen as glucose, the evolutionary preparation for physical action in response to threat. That glucose pours into your bloodstream. If no physical action occurs to consume it, insulin must clear it. In a body with insulin resistance, that clearance is slow and incomplete. The stress response designed to fuel physical survival is now elevating blood glucose multiple times daily in response to a phone notification, a difficult conversation, and the evening news. Think of it like having your fuel injection system triggered repeatedly by a faulty alarm that dumps fuel into an engine that is only idling. Research from psychosomatic medicine found that adults with type 2 diabetes who practiced daily structured relaxation showed measurably lower average blood glucose and HbA1c at 6 months compared to controls receiving standard diabetes education alone. The action step: 10 minutes of slow diaphragmatic breathing twice daily, 4 counts inhale, 4 counts hold, 6 counts exhale. This specific pattern activates the parasympathetic nervous system, reduces cortisol output, and closes the liver's glycogen release signal that stress was holding continuously open. 10 minutes, twice daily, no equipment, no cost. Number 8 is magnesium through food, and if necessary, supplementation. And this is the most consistently deficient micronutrient I identify in patients managing type 2 diabetes, with a mechanism that goes directly to the cellular biology of insulin receptor function. Magnesium is required as a cofactor for over 300 enzymatic processes. 2 are directly relevant here. The first is the autophosphorylation of the insulin receptor, the internal cellular step that completes the signal cascade after insulin reaches the cell surface. The second is the function of GLUT4 glucose transporters inside the cell itself. Both require adequate magnesium to operate at full efficiency. Think of it like a precision machine requiring a specific lubricant at 2 critical points in its operation. Without it, the machine runs, but at reduced efficiency with greater friction at every cycle. Research from Diabetes Care found that adults with the lowest dietary magnesium intake had a 19% higher risk of developing type 2 diabetes, and that in adults with established type 2 diabetes, magnesium supplementation improved fasting glucose and insulin sensitivity markers after 12 weeks of consistent intake. I had a patient, Barbara, 73, from Phoenix, Arizona, a retired social worker who had been following her diabetes diet and taking all prescribed medications carefully, but whose HbA1c had remained above 7.8 for 2 years without any movement. Her serum magnesium came back borderline deficient. We added magnesium glycinate at 200 milligrams nightly and increased dietary magnesium through spinach and pumpkin seeds. Her HbA1c dropped to 7.1 at her next measurement, the first meaningful change in 2 years. She told me, 1 mineral, that was the missing piece for 2 years. The action step, 2 cups of raw spinach daily, an ounce of pumpkin seeds 3 to 4 times weekly. If dietary sources are insufficient, magnesium glycinate at 200 to 300 milligrams at bedtime is the best absorbed form for most adults. Check with your physician before supplementing. Number 9 is a compressed overnight eating window. Finishing your last meal at least 3 hours before sleep and maintaining at least 12 hours without caloric intake overnight. And the mechanism runs through the same insulin receptor picture I described in the foundation. Insulin can only drop to its baseline floor during an extended period without caloric intake. During that low insulin window, your cells gradually restore receptor sensitivity, upregulating insulin receptor expression and clearing some of the ectopic fat deposits from the liver and muscle cells that were jamming the receptor mechanism in the first place. This is the primary mechanism through which time-restricted eating improves insulin sensitivity independent of total caloric intake. Think of it like giving the jammed locks an uninterrupted maintenance window, a period when the constant flood of insulin keys has stopped, and the repair machinery inside the cell can begin restoring receptor function without constant interruption. Research from Cell Metabolism found that adults with metabolic syndrome who ate within a 10-hour window without changing what they ate showed significant improvements in fasting glucose, insulin sensitivity, and HbA1c after 12 weeks, with the greatest improvements in those who most reduced nighttime eating. The action step: establish a fixed final eating time and hold it 7 days a week. If you currently eat at 8 or 9 at night, moving that window back to 6 or 6:30 and maintaining 12 hours of overnight fast produces measurable insulin sensitivity improvement without any dietary restriction or caloric change. Now drop a comment telling me which of these 10 habits is furthest from your current daily routine. I read every single one. Those responses tell me precisely where the real implementation barriers are for the people managing this condition every day. Number 10 is soluble fiber at every meal. Specifically soluble fiber, not the insoluble variety that most high-fiber product marketing emphasizes, because the mechanisms are categorically different and the distinction almost never gets explained clearly in clinical settings. Soluble fiber, found in oats, legumes, flaxseed, chia seeds, and specific vegetables including Brussels sprouts and asparagus, dissolves in water and forms a viscous gel inside the small intestine. That gel physically traps glucose molecules and the digestive enzymes breaking down carbohydrates, slowing both digestion and absorption simultaneously. Think of it like lining the inside of the glucose delivery highway with gradually thickening walls that narrow the lane progressively. The same total glucose arrives at the absorption surface, but at a fraction of the original rate, producing a flat and manageable curve rather than a sharp spike. Simultaneously, soluble fiber is fermented by gut bacteria into short-chain fatty acids, particularly butyrate and propionate, that directly inhibit hepatic glucose production between meals, reducing the background glucose contribution from the liver that compounds fasting blood sugar in most type 2 diabetics. Research from the American Journal of Clinical Nutrition found that adding 10 grams of soluble fiber daily to a standard diet reduced HbA1c by 0.58% and fasting blood glucose by 8 points over 12 weeks in adults with type 2 diabetes, effects comparable to some pharmaceutical interventions at that degree of HbA1c change, 0.58% from fiber alone. That is not a rounding error. I had a patient, Harriet, 76, from Memphis, Tennessee, a retired elementary school teacher whose post-meal glucose readings remained stubbornly elevated despite medication and careful portion control. Her diet appeared balanced but contained almost zero soluble fiber. Processed grain products, overcooked vegetables, no legumes. We added 2 tablespoons of ground flaxseed to her morning yogurt, half a cup of lentils at lunch 3 times weekly, and whole oats at breakfast 2 mornings a week. In 8 weeks, her post-dinner readings had dropped an average of 31 points. No medication change, no other dietary change. Fiber was the variable. She told me, "I had been eating carefully for 2 years and skipping the one thing that would have made it work." The action step: add ground flaxseed to 1 meal daily, include lentils or black beans in at least 3 meals this week, and replace any processed grain at breakfast with whole oats. These 3 changes reliably deliver the soluble fiber dose the research used. So here is how all 10 habits work as a single integrated system rather than 10 separate interventions. Post-meal walking activates the non-insulin glucose clearance pathway that bypasses the jammed lock entirely. Protein-first sequencing slows gastric emptying and flattens the glucose curve before the spike can occur. Vinegar inhibits carbohydrate digesting enzymes and hepatic glucose output simultaneously. Morning hydration reverses the overnight concentration effect that inflates fasting readings before food has been touched. Sleep consistency restores the 25% insulin sensitivity loss that even one night of poor sleep can produce. Resistance training builds glycogen storage capacity that reduces the insulin demand for any given glucose load while simultaneously creating a 48-hour recovery window of heightened glucose uptake. Stress reduction closes the cortisol signal that was triggering the liver to release glucose between meals throughout the day. Magnesium restores the enzymatic function at both the insulin receptor and the glucose transporter that deficiency was quietly compromising. The compressed eating window provides the overnight low insulin period during which receptor sensitivity can begin its recovery. And soluble fiber slows glucose absorption while simultaneously suppressing hepatic glucose production from inside the gut itself. These 10 habits are addressing the same problem, the jammed lock, from 10 different angles simultaneously. The reversal research that produced 46% remission rates at 1 year was not driven by one or two interventions. It was driven by multiple behavioral changes compounding through overlapping mechanisms in the same system. Remember Thomas, the retired engineer from Austin, whose post-dinner readings dropped 71 points from post-meal walking alone? He then added protein-first sequencing and the overnight eating window. His HbA1c at his 12-month mark was 5.9. He was no longer pharmacologically diabetic. His physician used the word reversal. Here is your plan starting today. This morning, drink 16 ounces of water before any food or coffee. At your next meal, eat protein first, vegetables second, carbohydrates last. After that meal, walk for 10 minutes within 30 minutes of finishing. Tonight, establish a final eating time that gives you at least 12 hours before your first morning food tomorrow, and set consistent sleep and wake times that you hold for the entire coming week. This week, add 2 tablespoons of ground flaxseed to one meal daily and include 1 serving of lentils or legumes in at least 3 of your upcoming meals. Prepare 1 tablespoon of raw apple cider vinegar in 8 ounces of water and take it 10 minutes before your 2 largest meals through a straw and mention it to your physician if you are on glucose-lowering medication. Schedule 2 resistance sessions this week, 20 minutes each, chair stands, wall push-ups, resistance bands if you have them. Practice 10 minutes of slow diaphragmatic breathing tonight before bed. Check your magnesium-rich food intake this week and discuss serum magnesium testing with your physician at your next appointment. And track your 2-hour post-meal glucose readings this week if you have a glucometer. Not to judge, but to establish the baseline against which these habits will produce measurable change faster than you expect. Now, here is something that connects directly to everything we covered today and deserves its own complete conversation. The specific breakfast pattern that the majority of adults managing type 2 diabetes eat every morning that is setting the glycemic tone for the entire rest of the day in the wrong direction before they have even left the house. Most people would not correctly identify the problem even after watching today's full video. The replacement pattern costs no more time or money and reverses that morning metabolic trajectory completely. That is exactly what I am covering next, and that video will be on your screen right now. I'm Dr. William.